Hi, I'm Joshua Gary. I'm an orthopedic trauma surgeon in Los Angeles, California. The CurvaFix is a new rod implant that allows us to place implants in the pelvic ring in corridors that aren't straight. It can be particularly helpful in patients with challenging anatomy or in patients where we need trans-sacral fixation, such as sacral dysmorphs, where we can't place that with straight implants. That would be a good starting point there. Image there. Okay, let's come back to the other view, please. Yeah, so I like that trajectory from low and posterior to more cranial and anterior. And again, here, if we're going to use a 9.5 implant, when we enter this entry drill bit over the wire, we're going to take it halfway in for the first 3 centimeters. Image. And again, you can use a soft tissue protector if you choose. Image there. Image. Image. Okay, can I get the flexible wire, please? Image there. One thing when you switch this out is you need to find the same soft tissue tunnel image there that you use your wire through. Image. Use the image there. Image. Image. All right, the steerable guide. Image there. Okay, image there. Image. There we go. Okay, image there. Okay, pull back to the midline a little bit and I'll come check the other view. Okay, great. So there we're in good position. We're not near the lateral border of the upper sacral nerve root tunnel yet. We can come to the inlet. So all that's been at risk right now is L4 and L5 if we were out cranial and anterior. Image there. Image. 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 Okay, let's come to the other view, please. One thing that can be more difficult if we try to come in a truly transsacral fashion is getting across a contralateral joint. So we had the rigid intraremur that went across the joint on this side. Depending on a patient's bone quality, there can be some challenges when we get to the other side. Image. Image there. Image. Can we go to the other view? So right now that the tip of that wire is just at the lateral border of the upper sacral nerve root tunnel. So the minute we cross that lateral border is the first time that S1 will have seen risk, the S1 nerve root. Image. And here we're behind that cortication of the upper sacral segment. Image. Image. And here we need to start heading just a little posterior. Image there. Image. Image. And again, this is where the bone quality really improves, is here in the sacral promontory. Image. Image. Okay, let's go back to the other view, please. So this is where you really have to spend your time with the wire and using your imaging to go back and forth is through this dense bone in the central sacrum. Image, 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 image. Now I'm going to start head and caudal, image there. Okay, let's come back to the other view. You can see the residual disc here, some mammillary bodies, which is a sign of the sacral dysmorphism. Pull back towards you, I think. Pull back. Push in just a little. Image there. Image. 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 Image there. Okay, let's come back to the other view, please. So that's in really good position there to be behind the indentations in the upper sacral segment on both the left and right sides. Many times those are symmetric. They can be asymmetric in some patients. Sacral dysmorphism has a lot of different varieties. Image there. Image. 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 Okay, come back to the other view now. So you can see we're going to be above the S1 foramina. Image. 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 And again, you've got to think four-dimensionally with these. Image. Image. Image there. Image, you can see heading towards the cortication. Image. Now we're going to head a little posterior. Image. 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 If I came out anterior to that cortication, L4 and L5 would be at risk. L4 and L5 nerve roots. Can we come to the other view, please? See, this patient has a lot of calcifications in their arterial system. You can see that on the imaging. Image there. Here that's heading towards that S1 foramina. Image. We'll back that up. Image. Image there. Image. 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 Come to the other view. Yep, can you roll back or roll over a little bit for me? Image. Roll back, double back on that. Yep, image there. Image. 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 Just push in just a little bit. Let me see. I'm going to back it up just a little. Image. Image. Image.
Can we go back to the other view, please?
Here, the structures at risk have, you really have to understand the anatomy of the nerve root tunnels to be safe. Image. 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 Okay, other view, please. All right, because the nerve root tunnels will run from central and posterior to peripheral and anterior. Anyone doing this should really read Chip Rout's paper on the anatomy of the upper sacral nerve root tunnels and understand that very well, and with your pre-op and post-op or pre-op imaging to plan. Let's come to just a little bit less inlet there. Just a touch. Yep, image there, Isaiah. Let's come the other way. Let's double back the other way. Image there. Image. Image. Now, there we're in a good position. We're near the other SI joint. Let's go to the outlet quickly. When we cross into the other ilium, this sharp wire can help, and you hope the bone quality is poor enough to allow this wire to just be impacted. You have options. You can either finish the CurvaFix in the contralateral ilium and bring it anterior, pull back a little bit. You got a little bit of ways to go to the SI joint. Image. Image. All right. So there we're right at the lateral border of the sacrum, contralaterally. Let's come back to the other view. So we can either try to bring this truly trans-sacral, transiliac and out both cortices, or we can end it in the contralateral ilium, bringing it a little bit anterior. And there we're in nice position heading anterior. Image. And you can see we're crossing into the image there, which is in fact here I'm up against the steerable. Image there. Right, you can see right where that image, to make sure. And here, sometimes the wire can start bending, so you have to put it very, very close to the steerable guide rod to see if you can get this through. But patients with better bone quality, you can really have difficulty getting that blunt ball tip through. Image. 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 And there you can see we're through. Let's come back to the other view. Great, so now what I want you to do, you can see we're in the other ilium. Roll back about 15-20 degrees to your side, so it'd be the obturator inlet image or the down the wing, like we used for the LC2 screw. Yep, roll back some more. You can see the SI joint coming into play there. Yep, roll back some more and we'll see that outer table image there. There we go. So that image there, you can see now we're coming anterior. Image. Image. And that should be a good ending point. So let's come back to the inlet now, and then we can, if you choose to, you can countersink, or you can measure. Image there. Can you push in just a little bit more and roll back some? Image there. And you want to make sure this is fully engaged. Roll back a little bit more for me, and then I'll have you check an obturator inlet. Image there. Yep, just a touch more. We'll get that symphysis over the center of the sacrum. Okay, great. There's a good outlet image showing the curve. Roll up to inlet, please, Isaiah, and then we'll roll over towards me. Do obturator inlet. Again, I've used inlet and outlet to start this today. Many people use the lateral sacral view. I think either is fine if you do your preoperative planning based off your imaging and CT scan. However, you can most safely start these to avoid nerve roots is a good thing. So now roll over towards me on that image and we'll make sure this is down. Keep coming. So this will be that same obturator inlet view we used on the other side. And roll back just a little bit. If you wanted to countersink, you could. Again, this is not a device for compression. This is once you have your reduction to maintain, and you can see that that's down. That measures between 140 and 150, so we could probably take a 140 on this one with the bend, and we're not going through the other cortex. We next passed our reamer. This is first a 7mm reamer. You can roll back, let's come back to the outlet. When we do the larger diameter reamers that go with the threads, we'll stop them about 2 centimeters short of our contralateral side to preserve the bone for its interaction with the threads on the far side of this image. If you can just pull back a little bit. There, yeah. Pull back a little bit more. Roll back just a touch more. Yep, there you go. Image. And you're really going to want to get this in-cutting reamer image past these cortices on the lateral sacrum image and the medial ilium image. So there we can take this one, image there. Image. Image. We can go 8.5. Yeah. Image. Yeah. Go back.
This one's 8.5.
That reamer, as it went over, the head of it did come off. But one thing that's really important is you always ream over a ball tip. So if we pull back a little bit, that reamer pull back had the ball tip, so if it would have broken off, we had a way to fetch that out. So you should never ream over anything other than a ball tip wire image. And that's why the exchange tube is so important. Image there. Image. So we'll stop this about 2 centimeters short there. Image. The steerable guide out without pulling our wire and use the exchange tube. Image there. There we go. Image. Put a pretty acute bend on that image. So again, you can see there that maneuvering of the exchange tube is important to turn it. Image there. Exchange tube stays in as this comes out. And again, if we need to, we can slightly bend one end of this wire if needed. Image there. Image. 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 Again, we didn't ream at the end. So one thing, if you'll roll straight up and down the inlet, we can use a hyper inlet image briefly. I can just show you sometimes the posterior limit. We typically use a straight inlet image, but if we're more posterior, come the other way, come up to inlet. Okay, now, so this would be a straight inlet image where we see the indentations in the front. Lay down about another 17 degrees from here towards the inlet this way. The average for a hyper inletter looking at the back of the canal is 17. Lay back just a little bit more. So you can use this image with your steerable guide wire as well. Image there. You can start to see the spinal canal. Lay back just a little bit more for me, Isaac. It'll look like a little triangle when you really get it right, and someone without a bunch of scoliosis. Image there.
image. So you can start to see the spinal canal there on a hyper inlet image. Image there. Great, and you can see we're anterior to it. So you can come back to the straight inlet now. Just take the tilt out. Image. Great, and we're going there. Now we can come to the outlet just to watch it accommodate the bend that we put. You can push in just a little, but you'll see this. Above the S1 or upper sacral segment foramina, image there. Image. And here we'll come to the other side. Image. Image. Image, and there it starts to turn down. If you're cranial and anterior at the lateral ala, you're really risking L4 and L5. Being behind those indentations on the inlet image is important. Image there. If you use the lateral sacral view, you can use the iliac cortical densities to help you, but you really have to understand the anatomy. Image there on your pre-op image. And again, here's where there's some better bone quality. Image. So sometimes a little bit of gentle forward pressure. Image as these threads engage. And again, we didn't ream those last 2 centimeters to get good purchase of our threads in the bone. Image there. Image. I think it really is important to make sure your reamers came across the SI joint, or at least one, the end cutting. Image. 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 Image there. So now you can see we're heading that way. Push in towards me a little bit so we can watch the CurvaFix dock on the lateral ilium contralaterally. Good, so now what we can do is we can come to an obturator and inlet image on this side. So come up to inlet, then roll over towards me and watch this seat. Roll back just a little. One good thing here is as we lever this off, having the fins parallel to the floor like you would a sliding hip screw will allow this screw to disengage. Or allow the handle to disengage. Image there. Roll over towards me just a little bit. Yeah. Okay, roll over just a little bit more. Tell you what, roll back. That's something worse. Roll back. And I'll pull back, just roll back, push in a little. Yeah, sorry, we're almost there. Image. Push in. Image. Okay, so we can see we're pretty well docked. Now we're going to lock the screw. We're going to release this, disengage the screwdriver, and then lever back and forth. Image there. Great, and you can roll back to the straight inlet and outlet. Just pull back just a little, and arc back a little bit more, and we'll get a good view behind those indentations in the upper sacral segment. Push in just a little, and then without the motion. Great, and we can come to an outlet. There we can see we're behind both indentations on the left and right side. slide it to more cranial. And here you can see we've taken a trans-sacral pathway, but used it really in 4 dimensions in a curve. You can drop your machine, you may get the whole thing on one. Maybe bottomed out. Yeah, let's see what we get. And there you go.